Botox is packaged in single-use vials of 100 units of botulinum toxin in a hemagglutinin complex and should be stored at -5 degrees Celsius. Make sure all the necessary equipment and materials are ready before starting the reconstitution procedure, and follow a sterile technique during it. The following materials will be needed. The recommended diluent is sterile, non-preserved normal saline. For the introduction of saline and for extraction of reconstituted Botox from the vial, we recommend 10 ml Luer syringes and 2.5-inch 21-gauge needles. Alcohol wipes help to maintain sterile technique. Botox is prepared by introducing an exact quantity of normal saline into the vial. 100 units are reconstituted with 10 milliliters of normal saline, resulting in 10 units per milliliter. To reconstitute Botox, first remove the plastic cap from the vial. Then, with a 21-gauge needle on a 10 milliliter syringe, draw up 10 milliliters of saline. Insert the needle, bevel side up, at a 45-degree angle into the Botox vial. Slowly inject the diluent, allowing the vacuum to draw the plunger down. Discard the vial if the vacuum does not pull the diluent into the vial. Once the saline has been injected into the vial, gently mix by rotating the vial. It is important that you do not shake it, as this could denature the product. Correctly reconstituted Botox should be clear and colorless. Once the vial is prepared, it is good practice to record the date and time of reconstitution on the vial label. For sterility purposes, once opened and reconstituted, Botox should be used within 4 hours. If being stored before use, it should be stored at between 2 and 8 degrees Celsius in a refrigerator. This product is for single use only, and any unused solution should be discarded. To withdraw Botox from the vial, simply tilt the vial and push the needle to the lowest corner. Because the needle has a broad bevel, it should be flush with the corner, allowing you to draw the entire amount into the syringe. The syringe should be held needle up and tapped to allow any trapped air to rise and be pushed out. In addition, if alcohol wipes have been used to clean any of the equipment, the alcohol should be allowed to evaporate completely. Once Botox has been drawn into the syringe and any air expelled, it should be disconnected from the needle. The syringe is now ready for intradetrusor injections. Before the injection procedure takes place, informed consent must be obtained from the patient and a urine dipstick performed to exclude any infection. Prior to being cystoscoped, the patient should receive antibiotic prophylaxis against any urinary tract infection. The injection procedure is carried out using either a flexible or a rigid cystoscope, instruments that will be familiar to you from other urological procedures. For the minimally invasive technique using the flexible cystoscope, local anesthetic such as lignocaine gel is applied to the urethra. For rigid cystoscopy, regional or general anesthesia may be required. Access to the bladder is via the urethra. Adequate draping and aseptic technique must be used. For the minimally invasive intradetrusor injection of Botox, a superfine 27-gauge single-use 4 mm needle is recommended. The needle should be used in conjunction with a flexible, reusable sheath into which it locks. The exact number of injections may vary depending on the specific clinical situation. For example, a 200-unit dose in 20 milliliters of saline may be injected as 1 milliliter, 10 units, at each of 20 points, or with a 300-unit dose in 30 milliliters injected into 30 points. For the most effective treatment, the full length of the needle should be buried in the bladder wall during injection. Injection site pain is usually low, although there may be some discomfort due to the unfamiliar situation. If the patient is unable to tolerate the injection, the bladder may be instilled with 40 milliliters of 2% lignocaine for 20 minutes. Inclusion criteria for minimally invasive intradetrusor injection of Botox are: proven overactive bladder, overactive bladder refractory to anticholinergic treatment. Patient is willing and able to perform clean intermittent self-catheterization. Exclusion criteria for the procedure are: urinary tract infection at the time of injection, pregnancy or planning a family, patient is on anticoagulants, e.g. warfarin, bladder malignancy. During the procedure, the bladder should look similar to the example shown here. Thank you for taking a few minutes to review the preparation and use of botulinum toxin type A purified neurotoxin complex for the overactive bladder. You may now wish to review the clinical and scientific evidence for the use of Botox in this indication.